Think about this. The ancient Code of Hammurabi, thousands of years ago, well, it already recognized the profound importance of blood. They even had laws about it.
Yeah, and the Babylonian creation myth, blood was seen as the very essence of life.
It really hits home how absolutely fundamental good circulation is to our health. A fact that becomes especially clear when we're taking a deep dive today into arterial disease ulcers of the lower extremity.
Exactly. We're focusing on these wounds that pop up, on the legs and feet because the arteries, those vital pathways for blood, they've become narrowed, restricting that essential flow.
It might sound kind of simple, cause and effect, but the chain of events leading to these ulcers and how we manage them, well, it's actually quite intricate.
It really is.
And for you, our listener, we know you're looking to get a solid handle on this without getting bogged down in complicated medical jargon. Our mission is really to pull out the crucial insights from a detailed medical article so you can understand what's going on.
Right. This article walks us through how these ulcers are diagnosed, what tests are needed to understand the underlying issues, and the different ways they can be treated. It's pretty comprehensive.
Yeah, and we're here to give you the important takeaways. Precisely.
Mhm.
By the end of our discussion, you'll have a clearer picture of what causes these ulcers, how doctors spot them, and the various approaches to treatment, really focusing on what leads to the best outcomes. Okay, let's get started by unpacking what we mean when we talk about reduced blood flow.
Okay. So at the most basic level, it boils down to ischemia and hypoxia. Ischemia is when the blood supply itself is restricted, usually because the arteries have narrowed or gotten blocked, kind of like a pipe getting clogged.
Okay.
And this reduced blood flow then leads to hypoxia, which is when the tissues just don't get enough oxygen. It's a bit like a plant not getting enough water.
Right.
Now, hypoxia in the tissues, it's a major roadblock to any kind of proper wound healing.
So if you get a little cut on your leg and you have this kind of reduced blood flow, it's not just going to take a bit longer to heal. It's a much bigger deal.
Oh, absolutely.
The article mentions something called critical limb ischemia. What exactly is critical about it?
Yeah, critical limb ischemia, that really emphasizes how severe and long-lasting the problem is. Think of it as the danger zone of poor circulation in the legs.
Okay.
The Inter-Society Consensus, TAS C2, defines it as having chronic pain in the legs, even when you're resting or, developing ulcers or gangrene, all because there's a proven significant blockage in the arteries.
Wow.
This is way beyond just feeling pain when you walk that goes away when you stop. This is a constant threat to the health of the limb.
That really paints a picture of a limb in, well, serious distress. How often do these kinds of severe arterial issues, the ones that lead to ulcers, actually happen?
Well, it's interesting. A lot of adults have some degree of peripheral arterial disease. The article mentions maybe 14 to 20%, but the specific issue of arterial insufficiency causing lower extremity ulcers, that accounts for about 8% to 10% of all such ulcers.
Oh, okay.
So while venous ulcers might be more common overall, arterial ulcers are still a significant problem that, doctors really need to be aware of.
Okay, we've got a handle on what we're talking about. Now let's dig into what's actually going on in the body to cause these arterial ulcers in the first place.
Right. So the main reason for peripheral arterial disease, which, leads to critical limb ischemia and these ulcers, in the buildup of cholesterol plaque inside the arteries.
Atherosclerosis.
Exactly, atherosclerosis. And it makes the arteries narrower, kind of like sludge building up in a pipe, just reducing how much blood can actually flow through.
So it's the same kind of buildup that can cause heart problems, strokes, but it's happening down in the leg vessels.
Precisely. And when this narrowing gets really bad, we hit that point of critical limb ischemia, where even when you're just sitting there, lying down, your tissues aren't getting enough blood to meet their basic needs.
Right.
The article highlights a really important point. It becomes a vicious cycle. Less blood flow means less oxygen.
And that oxygen shortage just throws a wrench in all the body's processes for healing wounds, right?
Absolutely. It messes everything up.
Like what does oxygen do for fixing a wound?
Oh, oxygen is vital for so many things.
Yeah.
It's needed for cells to grow and multiply to repair the damage, for making collagen, that's kind of like the scaffolding that holds new tissue together,
Okay.
for creating new tiny blood vessels to bring in more nutrients, and even for our immune cells to fight off any infection. When there isn't enough oxygen, all of these crucial steps are severely hindered. Just can't happen properly.
That makes perfect sense. It's not just getting blood there. It's the oxygen the blood carries that's the real fuel for healing. Are there other things besides this cholesterol buildup that can cause these arterial ulcers.
Yeah, while atherosclerosis is definitely the most common culprit, the article lists a few other possibilities. These can include injuries to the arteries themselves, sudden blockages from blood clots that travel through the bloodstream, that's embolism,
Right.
diabetes, which can damage blood vessels over time, Berger's disease, that's an inflammatory condition affecting smaller arteries and veins, and some rarer conditions like certain genetic disorders and vasculitis. So a few different pathways can lead to that same issue of reduced blood flow.
It sounds like a lot of different roads can lead to the same destination of, compromised circulation. And the article mentioned that even small injuries can trigger these ulcers in someone with poor blood flow.
That's a key thing to understand, yeah. If the blood flow to a limb is already significantly reduced, even a minor bump, maybe a tight shoe causing pressure, or just a small crack in the skin can be enough to start an ulcer. The circulation's already struggling, it just doesn't have the resources to heal even a tiny injury. And similarly, if an infection starts in a limb like that, it's much harder for the body to fight it off without first improving the blood supply. It's like trying to put out a fire with just a trickle of water.
So it's like the body has no reserves to deal with even small setbacks. And if nothing is done, what usually happens with these ulcers? Do they just stay there?
Unfortunately, no. If the underlying artery problem isn't addressed, these arterial ulcers tend to get worse. They can become more and more painful. They have high risk of infection because, well, the healing process is impaired.
Makes sense.
And in the most severe cases, they can sadly lead to the need for amputation. Restoring blood flow, what we call revascularization, is often the key to stopping this downward spiral.
Okay, so we understand the why behind these ulcers. Now, how does a doctor actually recognize them? What are the telltale signs they look for?
Well, spotting P8 early is really important because it gives us crucial information about a person's overall health outlook. The sooner it's identified, the sooner we can think about interventions.
Right.
The article emphasizes that any ulcer on the lower leg or foot should make a clinician think, could this be artery related? And if there's any suspicion, getting a vascular surgeon involved is vital.
And I remember reading about the 6Ps in the article. What's that a reminder of again?
Yes, the 6Ps.
Yeah.
It's a handy way to remember the classic signs of a sudden severe blockage in an artery, which can also show up in very severe chronic cases leading to ulcers.
Okay, what are they?
They are pulselessness, meaning you can't feel a pulse in the limb, pain, often quite severe, pallor, the limb might look pale, pallor, meaning cold to the touch, punched out defect, which describes that typical sharp-edged look of the ulcer, and pressure cites the areas where these ulcers often pop up.
Okay.
So these aren't just isolated symptoms. They paint a picture of a limb in severe distress, demanding immediate attention.
That's a good way to remember the key warning signs. Are there other visual clues a doctor might notice, like just looking at the leg?
Absolutely. In more advanced long-term disease, you might see changes in the skin, like hair loss on the legs and feet, and the skin might appear very smooth and shiny. The toenails can become thick and yellowish. That's called onychographosis. Muscle wasting in the leg can also be a sign of chronic lack of blood flow.
Right.
And the color of the toes can change depending on how severe the ischemia is, starting with paleness, then maybe a bluish or grayish color, then purple, and eventually black if gangrene sets in.
That paints a pretty stark picture. And what about the ulcers themselves? What do they usually look like, and where do they tend to show up?
Arterial ulcers often have a very distinctive look. They're frequently described as having sharply defined edges, like someone took a hole punch to the skin. Yeah, they can be quite deep. And they commonly occur right on the tips of the toes, on the top of the foot, on the heel, and along the front of the shin. These are areas where the blood supply is often most vulnerable in areas that bear pressure.
Makes sense.
The base of the wound often looks pale and doesn't have that healthy, red, bumpy granulation tissue you'd expect in a healing wound. It might even have black, dead tissue, necrotic tissue in it. In severe cases, the ulcer can go deep enough to expose tendons and bone.
And the pain that comes with these ulcers, is it different from the pain you might get with other kinds of leg ulcers, like venous ones?
Yes, the pain from arterial ulcers is often quite intense. A key characteristic is that it tends to get worse when the leg is raised up.
Oh, right.
Because gravity isn't helping get blood down to the limb. On the other hand, people often find some relief by letting their leg hang down, like dangling it over the side of the bed or sitting in a chair. This position helps blood flow a little better through alternative pathways, collateral vessels. In fact, the habit of sleeping with their legs hanging down is a significant clue that points towards an arterial problem.
That's a really good clinical clue.
It is, but it's also important to remember that some people, especially those with nerve damage like diabetics, might not have typical pain or might not have any pain at all, even with a severe arterial ulcer.
So the absence of pain doesn't rule it out.
Definitely not. You
Well,
can't rely on pain alone, especially in certain groups.
that's a really important point. The article also mentioned the Rutherford and Fontaine classifications. What are those used for?
Those are systems that doctors use to classify how severe someone's chronic limb ischemia is based on their symptoms, like whether they have ulcers, gangrene, or pain even when resting. These systems help to standardize how we assess the condition and allow doctors to communicate clearly about how advanced the disease is. Generally, if someone has an ulcer, gangrene, or rest pain due to arterial disease, they fall into the more severe categories of these classifications, indicating critical limb ischemia.
Got it. And before we move on to tests, the article brought up the ABCDE's mnemonic for risk factors for atherosclerosis. Can you give us a quick rundown of those?
Absolutely. The ABCDEs is a helpful reminder of the major risk factors that contribute to the hardening and narrowing of the arteries. A1C reminds us to check for and manage blood sugar, as diabetes is a major risk.
Right.
Blood pressure highlights the importance of controlling high blood pressure. Cholesterol emphasizes the role of high cholesterol in plaque buildup. Diet and obesity point to the impact of unhealthy eating and excess weight. Exercise underscores the protective benefits of regular physical activity.
Yes.
And finally, smoking, which, as we've heard, has a really significant negative impact on circulation. Even a single cigarette can have lasting effects. It's a huge factor.
Smoking really does seem to be a common thread in so many health issues. Okay, so a doctor suspects an arterial ulcer based on these signs and symptoms. What are the essential examinations and investigations they'll do to confirm the diagnosis and see how bad the problem is?
Right. The first step is always a thorough physical exam, starting with checking the pulses in both arms and legs. If pulses are weak or absent in the legs, that's a strong sign of PAD and can even give an idea of where the blockage might be.
How do they grade them?
Doctors usually grade the strength of the pulses on a scale from 0 to 2, with 0 being no pulse and 2 being a normal pulse. The absence of the posterior tibial pulse, which is the one in your ankle, is often a red flag for PD.
Okay.
However, just because you can feel a pulse doesn't completely rule out a problem, especially if the ulcer is in a specific area of the foot supplied by a different artery branch. Yeah.
Sure. And we also heard about capillary refill and the Berger test. How do those help?
Yeah, capillary refill is simple. You press on the skin, see how quickly the color returns. If it takes a long time in the foot, it suggests poor blood flow.
Mm-hmm.
The Berger test involves lifting the leg up, maybe 45 degrees, for a minute, and watching to see if it turns pale. Then you hang the leg down and see if it turns really red. If the color takes a while to come back when the leg is lowered and it becomes very red, or ruberous, that can indicate significant arterial insufficiency.
Okay. The article also mentioned checking for nerve problems.
Yeah.
Why is that so important when dealing with leg ulcers?
A neurological assessment is crucial, yeah.
Yeah.
You need to see if there's any nerve damage, especially diabetic neuropathy happening at the same time. Doctors might use the SAM acronym, sensory, autonomic, and motor function, as a reminder of what to check.
A SAM, okay.
And the 5.07 monofilament test, where they gently touch the foot with a thin nylon fiber, that's a standard way to check if someone has lost protective sensation.
Why does that matter here?
Well, if there's nerve damage, it can mask the typical pain of an arterial ulcer, like we talked about, or even lead to ulcers in unusual places because the person can't feel pressure or injury. So it's important to know if it's a factor. An ulcer that has both poor blood flow and nerve damage, a neuroischemic ulcer, often points to more widespread vascular disease.
Okay, now we're getting into some of the more specific tests. The Ankle-Brachial Pressure Index, or ABPI, seems like a really important one. Can you break that down? Why is it so vital?
The ABPI is definitely the go-to first test for diagnosing PAD and is absolutely essential when looking at any lower leg or foot wound. It's a simple ratio, really.
How's it calculated?
You take the highest systolic blood pressure in the ankle, using a handheld Doppler ultrasound to hear the pulse, and divide it by the highest systolic blood pressure you find in either arm. Think of it as comparing the blood pressure way down in your leg to the pressure in your upper body.
So comparing the squeeze in the leg vessels to the arm vessels, what do the different numbers tell us?
Generally, an ABPI of less than 0.9 is considered abnormal and suggests PAD. If it's below 0.5, especially if there's an ulcer present, that strongly suggests critical limb ischemia.
And that means?
That usually means a very urgent referral to a vascular surgeon, because just treating the wound locally is unlikely to work. The blood flow needs fixing.
What about high numbers?
Interestingly, yes, an ABPI of more than 1.4 is also considered abnormal. This can happen when the arteries in the leg are very stiff and calcified, which you often see in people with diabetes or kidney disease. It makes the pressure reading artificially high.
So the reading isn't reliable then?
Exactly. In those cases, looking at the blood pressure in the toes, the toe pressures, might give a more accurate picture.
Ah.
And the article also points out that any abnormal ABPI reading, whether it's too low or too high, is linked to a higher risk of heart attack and stroke. So it's not just about the leg, it's a window into overall cardiovascular health.
That's huge. It's a warning sign for the whole system. And you mentioned toe pressures. How do those work and when are they useful?
Right, so in those patients with really stiff leg arteries, where the ABPI might be misleadingly high, toe pressures measure the blood flow in the smaller arteries in the toes. These smaller vessels are less likely to be stiff and calcified, so the readings are usually more reliable.
And what numbers are you looking for there?
A toe pressure of 50 millimeters of mercury or higher is generally considered good enough for healing, even in diabetics. Pressures between 20 and 30 millimole of JG suggests significant problems with blood flow and difficulty healing. And if the toe pressure is below 30 millimole G in someone with an arterial ulcer, it's a strong sign they need intervention to improve circulation.
That makes sense. If the big arteries are stiff, look at the smaller ones for a clearer picture of tissue blood flow. Now, the article also talked about transcutaneous oxygen pressure, or TCPO2. What does that measure and how does it help?
TCPO2 is a really useful tool because it directly tells us about the oxygen levels in the tissue right around a wound. It measures the partial pressure of oxygen diffusing out through the skin.
So it's a direct reading of whether the tissues are getting enough oxygen.
Pretty much, yeah. A TCPO2 of less than 40 millimole G while someone is breathing normal air usually means the tissue is oxygen-starved, hypoxic. And a reading below 30 millimole G is a strong indicator of critical limb ischemia.
So it's a more direct way to see if the tissues have enough oxygen to heal. How do doctors use this information?
Well, TCPO2 can help predict whether a wound has a good chance of healing on its own. It also helps doctors decide if someone might benefit from procedures to improve blood flow revascularization and then to see how well those procedures actually worked.
How so?
If the TCPO2 goes up to above 40 millimole G after a revascularization, it's a good sign that the wound is much more likely to heal.
Okay.
And interestingly, if someone is being considered for hyperbaric oxygen therapy, a TCPO2 measurement taken while they're in a hyperbaric chamber, breathing oxygen can help predict if that therapy is likely to be successful for them.
That's fascinating, using oxygen levels to guide oxygen therapy. The article briefly mentioned Doppler arterial waveforms and segmental Doppler pressures. Are those done routinely?
Those are a bit more specialized, usually done in vascular labs. Doppler arterial waveforms look at the pattern of blood flow in the arteries. Is it nice and triphasic or flattened out? It can show if there are blockages or narrowing.
And segmental Dopplers?
Segmental Doppler pressures involve taking blood pressure readings at different points along the leg, thigh, calf, ankle to help pinpoint where the arterial problems are located. They give more detailed information, but aren't always needed for the initial diagnosis of an arterial ulcer.
Gotcha. And what about imaging, like angiograms? When do those come into play?
Imaging studies like traditional angiograms, CT angiograms, or MR angiograms, those are primarily used by vascular surgeons to get a really detailed map of the arteries. It's like a roadmap for them.
To plan surgery.
Exactly. It helps them plan precisely what kind of procedure might be needed to restore blood flow. But the article emphasizes that not everyone with an arterial ulcer will need surgery, so these more involved, sometimes riskier, and costly tests aren't necessary for every single patient.
So it's really a step-by-step approach. Physical exam, ABPI, maybe TCPO2 or toe pressures, and then imaging if intervention is planned. Based on all this, when should someone with a suspected arterial ulcer be urgently sent to see a vascular surgeon?
The article gives us clear triggers for an urgent referral. These include having pain in the legs, even when resting, rest pain, any signs of gangrene or significant discoloration, the ulcer itself being present, an ABPI of less than 0.5, or a TCPO2 reading below 40 millimole Hg.
Okay.
All of these findings suggest a high risk of losing the limb and indicate that prompt assessment by a vascular specialist is needed to consider ways to improve blood flow urgently.
Okay, we've talked about how these ulcers develop, how to spot them, and the important tests. Now let's get into what can actually be done to treat them. What are the main approaches?
Right. The article really stresses that managing arterial ulcers needs to be a really comprehensive effort. It has to be based on the best evidence and involve a whole team of healthcare professionals and Always keep the patient's needs and goals at the center.
A holistic approach.
Exactly. They recommend using a systematic approach to assess the wound, make the diagnosis, and plan treatment. Creating a care plan that looks at all aspects of the patient's well-being, including their pain, how the ulcer is affecting their life, their social situation, that's really important.
But what's the most crucial thing?
The most crucial thing, when possible, is to fix the underlying blood flow problem through urgent revascularization. Because these patients aren't just at risk for limb loss, they also have a significantly higher risk of heart problems and stroke. You have to address the root cause.
So it's not just about patching up the wound, it's about the bigger picture of their blood vessel health. The article mentions two main treatment strategies: improving circulation and improving oxygenation. Can you tell us more about those?
Yeah, so improving circulation primarily means doing procedures to open up or bypass the blocked arteries revascularization, which we'll definitely talk more about. But it also includes making sure the patient is on the right medications to manage their risk factors like cholesterol and blood pressure and prevent further artery problems.
And improving oxygenation.
Improving oxygenation focuses on getting more oxygen to the tissues. This might be by increasing the amount of oxygen in the blood the patient breathes, or maybe by helping the blood deliver that oxygen more effectively to the wound area. The article also emphasizes, and this is vital, protecting the already damaged tissues from any further injury. Don't make it worse.
And what about medications? Are there drugs that can directly help these ulcers heal?
Well, the best medical therapy really focuses on tackling those cardiovascular risk factors we mentioned, with the ABCDEs stopping smoking, lowering bad cholesterol with statins, controlling blood pressure and blood sugar, and using antiplatelet medications like aspirin or clopidogrel to prevent clots.
So managing the underlying disease.
Right. This helps prevent more problems down the road and reduces the risk of complications. However, the article points out that there aren't really any miracle drugs that directly heal advanced arterial ulcers once they've formed. Some medications have been studied, but current guidelines don't strongly recommend them for routine use, just for improving ulcer healing itself.
It sounds like medications play more of a supportive role in managing the overall health issues. What about some of the newer treatments I've heard about, like gene therapy or stem cell therapy? Are those helpful?
That's a good question. Gene therapy using growth factors to try and stimulate new blood vessel growth, well, it's shown some promise in early studies, especially for people with severe blockages who aren't good candidates for traditional surgery or endovascular procedures. But we definitely need more research there.
And stem cells.
Stem cell therapy, where cells are injected into the leg to try and improve blood flow and healing, has also had some encouraging results in reducing pain and helping ulcers heal in some small studies. But again, this is still very much a developing area and not yet a standard treatment you'd find everywhere.
So still mostly in the research phase, not routine practice yet.
Yeah.
What are some of the more basic things someone with an arterial ulcer needs to do for self-care? Things they can control.
Lifestyle changes are absolutely key. This includes trying to exercise regularly, even if it's just short walks, within their pain limits, to help improve circulation and other blood vessels, the collaterals.
Okay.
Absolutely stopping smoking is non-negotiable. Keeping the legs warm, staying well hydrated, and taking extremely good care of their feet are also vital.
What does good foot care involve here?
It means wearing soft, well-fitting shoes, checking their feet daily for any new sores or red spots, avoiding any bumps or scrapes, protecting their feet from very hot or cold temperatures, like hot water bottles or cold packs, making sure they're eating a healthy diet with enough protein to support healing, and staying hydrated are also really important baseline things.
Pain can be a really big issue with these ulcers, as we discussed. How is that usually managed?
Yeah, managing pain is a top priority, absolutely. The article recommends using a consistent pain scale to regularly check how much pain the person is in.
And treating it.
Well, addressing the underlying blood flow problem, the ischemia, is the most effective way to reduce the pain in the long run. For immediate pain relief, they suggest a step-by-step approach, like the WHO pain ladder, starting with non-opioids like acetaminophen or NSAIDs cautiously, then maybe moving to mild opioids, and then stronger prescription pain medications if needed, always under close medical supervision.
What about nerve pain?
Right. They also mention specific medications that can help with neuropathic pain, that burning, tingling, shooting pain, which can sometimes be a component, using drugs like gabapentin or pregabalin. And just from a basic care perspective, making sure the leg is in a comfortable, dependent position, avoiding those temperature extremes, and protecting the limb from further injury can also help manage the pain level.
Now let's talk about taking care of the wound itself, the local care. What are the main principles there?
The main goals of local wound care are really to prevent infection, avoid causing any more damage, and create an environment that can support healing, if that's actually possible given the blood flow.
So how do you clean them?
Gently cleaning the ulcer with normal saline solution or just potable water is usually best. Harsh cleansers like iodine, chlorhexidine, hydrogen peroxide, those should generally be avoided because they can actually be toxic to the healthy cells trying to heal the wound. They can slow things down.
Okay, no harsh stuff. What about removing dead tissue, debridement?
That's a really important point. If an ulcer is considered non-healable because the blood flow is just too poor, maybe ABPI 0.5, toe pressure 30, or TCPO 230, trying to surgically remove dead tissue or debride it might actually make things worse.
How so?
Because removing tissue increases the local demand for oxygen and nutrients, which the compromised circulation just can't supply. So if there's just dry, black, stable dead tissue, dry gangrene, it's usually best to leave alone, keep it dry, and protect it. Let nature wall it off.
But what if it can heal?
Right. If there's a chance the wound can heal because there's adequate blood flow, say ABPI 0.5 or TCPO2 30-40 mmHg, especially after revascularization, then careful removal of dead or infected tissue using various methods, sharp, enzymatic, autolytic, might be considered to help the healing process along. But it needs careful assessment first.
So it's all about figuring out if healing is even possible before being too aggressive with the wound care itself. What about dressings? What kind are typically used for arterial ulcers?
The choice of dressing needs to be tailored to the specific situation, and especially to whether the wound is deemed healable or non-healable.
Okay, so for non-healable ones.
For wounds that aren't likely to heal, the focus is on keeping them dry and clean, managing moisture. So you might use simple non-stick dressings, maybe gauze, something that could absorb any small amount of drainage. Sometimes antimicrobial dressings or topical agents like povidone iodine or silver products might be used cautiously to reduce the bacterial load, again being careful not to damage surrounding tissue. The goal is moisture reduction and bacterial reduction.
And for the healable ones?
For wounds that have a chance of healing because there's better blood flow, non-stick dressings that help keep the wound bed moist but not wet are usually preferred to support the natural healing processes. The article points out that the specific type of advanced moist dressing itself probably doesn't make a huge difference compared to just maintaining that moist environment.
Anything else about dressings?
Yes, because the skin around these ulcers is often very thin, fragile, and easily damaged. You need to be really careful with tapes and adhesives. Soft, silicone-based tapes or dressings can be a gentler option. And tight bandages should always be avoided as they can further restrict blood flow. That's crucial.
Compression therapy, like those tight bandages, is often used for venous ulcers. Is it ever used for arterial ulcers?
Generally speaking, no. Compression therapy is usually contraindicated for pure arterial ulcers because squeezing the leg can worsen the already poor arterial inflow.
Makes sense.
However, in some cases where someone has a mix of both venous and arterial problems, mixed ulcers, a team of experienced specialists might very carefully consider using modified or reduced compression if there's objective evidence, like from ABPI or Doppler studies, showing there's still sufficient arterial supply to tolerate it.
So only in specific mixed cases and very carefully.
Exactly. And even then, excessive compression must be avoided, and patients need to be told to report any increase in pain immediately, as that could be a sign the compression is too much.
Are there any other treatments, what the article calls adjuvant therapies, that might be helpful in certain situations?
Yes, for wounds that are deemed healable, after the underlying blood flow issues have been addressed as much as possible, some other things might help. Treatments like skin grafts, taking skin from another part of the body, or using skin substitutes can sometimes help close the wound faster once a healthy base is formed.
What else?
Spinal cord stimulation has been shown to help reduce pain and potentially save limbs in some patients with severe, non-reconstructible arterial disease. Intermittent pneumatic compression, which involves inflatable cuffs that gently squeeze and release the leg, might also help improve blood flow and healing in some cases.
Anything that doesn't have strong evidence.
Right. The article mentions that there isn't strong enough evidence yet to routinely recommend things like certain biomaterials or growth factors applied directly to the wound, therapeutic ultrasound, electrical stimulation, or even topical negative pressure wound therapy wound vacs specifically for promoting healing in arterial ulcers. And there are even some cautions about using negative pressure if the blood supply is really poor, as it could potentially make ischemia worse in some situations.
Okay. Infection is a really serious concern with these ulcers. How is infection typically managed?
Keeping infection under control is absolutely critical, yeah. The article mentions two helpful acronyms to remember the signs. NERDS for signs of a superficial or local infection in the wound bed, non-healing, exudate increase, red friable tissue, debris, smell, and stonies for signs of a deeper or more widespread systemic infection spreading beyond the wound. Size increase, temperature increase, AWS, probing to bone, new breakdown, exudate increase, erythema, smell.
Stonies. Got it. So how do you treat it?
If it looks like there's just a local infection based on NERD signs, topical antimicrobial treatments applied directly to the wound might be enough. But if there are signs of a deeper or systemic infection, the Stonies signs, then oral or even intravenous antibiotics are necessary based on likely organisms and culture results if available.
And blood flow.
Yes. The article stresses again that getting enough oxygen to the tissues is vital for both preventing and fighting infection effectively. Our immune cells need oxygen to work properly. Generally, doctors will avoid doing major surgical cleaning or debridement of the wound before blood flow has been improved, unless there's a severe, rapidly spreading infection that's threatening the patient's life or limb.
Okay, now let's dive into those perfusion strategies you mentioned earlier. Revascularization really seems to be a cornerstone of treatment, doesn't it? What are the different options for improving blood flow?
It really is the cornerstone. Restoring blood flow, revascularization to the affected limb is definitely the primary goal whenever it's feasible. There are two main ways to do this: endovascular procedures and open surgical procedures.
Tell me about endovascular first. Less invasive.
Generally, yes. Endovascular options involve using thin tubes called catheters that are threaded inside the arteries. Through these, doctors can do things like angioplasty, where a tiny balloon is inflated to push the plaque aside and widen a narrowed artery, often followed by placing a stent, which is like a tiny metal mesh scaffold to help keep the artery open. Other techniques like subintimal angioplasty, where they create a new channel alongside the blockage, or using drug-coated balloons that release medication to prevent renarrowing are also options depending on the situation.
And surgical options.
Surgical procedures are more traditional open operations.
Yeah.
They include endarterectomy, where a surgeon actually opens the artery and physically scrapes out the plaque buildup.
Okay.
Or arterial bypass, where a new route for blood flow is created to go around the blockage. This is done using either a vein taken from the patient's own body, usually the saphenous vein from the leg, which is generally preferred because it lasts longer, or sometimes a synthetic graft if a suitable vein isn't available.
How do they decide between endovascular and surgery?
That's a complex decision. Studies like the Basel trial have looked at this. It seems surgical bypass might be better in the long run for patients who are generally healthier and expected to live longer, especially if they have a good vein available. Angioplasty might be preferred for patients who are frailer, have shorter life expectancies, or don't have a suitable vein, or if the blockage type is more suited to it.
So lots of factors.
Many factors. Where the blockage is, how long it is, how severe it is, the patient's overall health and other conditions, the availability of a good vein, and frankly, the expertise available at that medical center. The angiosome principle is also increasingly used.
What's that?
The angiosome principle looks at which specific artery normally supplies blood to the precise anatomical area where the ulcer is located. The idea is that directing the revascularization specifically to that artery might give the best chance of healing the ulcer.
Interesting.
And it's really important to note, the article says age itself is not a reason to automatically rule out revascularization. Older patients can still benefit significantly.
Good point. So it's either going in with minimally invasive tools like balloons and stents, or a more traditional surgical detour with a bypass.
That's a good way to summarize it, yeah.
And what about those oxygenation strategies beyond just getting more blood there? You mentioned normobaric and hyperbaric oxygen therapy.
Right, so normobaric oxygen is simply giving the patient a higher concentration of oxygen to breathe than room air, but at normal atmospheric pressure, usually through a face mask or nasal prongs.
Does it help much?
The article points out that it's often underused, actually, even though there's pretty good evidence it can help with wound healing and prevent infection, especially around the time of surgery. Breathing higher levels of oxygen increases the amount of oxygen dissolved in the blood plasma, not just attached to hemoglobin.
Okay.
And this dissolved oxygen can then diffuse more easily out into the tissues, especially those that are struggling for oxygen.
And hyperbaric oxygen, that sounds more intense.
It is. Hyperbaric oxygen therapy, or HBO, involves putting the patient inside a special pressurized chamber and having them breathe 100% oxygen, usually at 2 to 3 times the normal atmospheric pressure.
Wow. Why do that?
This dramatically increases the amount of dissolved oxygen in the blood, like 10 to 15 times more than breathing air at normal pressure. This super-oxygenated blood can reach areas with poor circulation much better. HBO also has other beneficial effects, like stimulating the growth of new tiny blood vessels, helping fight certain types of infections, and reducing swelling.
When is HBO typically used for these ulcers?
HBO is generally used as an adjuvant therapy, meaning an additional treatment, for arterial ulcers. It's typically considered when revascularization isn't possible or when an ulcer isn't healing well, even after revascularization has been done.
But not for everyone.
No, definitely not. The key is that there needs to be evidence that the tissues are indeed oxygen-starved, hypoxic, but that this hypoxia can be improved by breathing hyperbaric oxygen. This is often assessed with that special TCPO2 measurement done inside the hyperbaric chamber, the hyperbaric challenge test. If the oxygen levels in the tissue jump up significantly during the test, it suggests HBO is likely to help.
So HBO isn't a first-line treatment, but can be a really valuable tool in specific, carefully selected situations where tissue oxygen can be boosted.
Exactly. It's an adjunct, not a replacement for addressing the underlying perfusion problem if possible.
The article also emphasized how important it is to educate patients. What kind of things do they need to learn?
Oh, patient education is absolutely vital for successful long-term management. Patients and their families need to learn how to monitor their circulation, checking foot temperature, color, looking for new sores daily. They need to recognize any signs that things are getting worse and know who to call.
And the lifestyle stuff again?
Absolutely. Completely avoid smoking. Engage in regular exercise as much as they can tolerate. Manage any other health conditions like diabetes and high cholesterol meticulously. Take incredibly good care of their feet to prevent any further injury, proper footwear, nail care, moisturizing dry skin. Understand how to properly care for their existing ulcers if they have them, and know exactly when they need to seek urgent medical help. Empowerment through knowledge is key.
Finally, in some very serious cases, amputation might have to be considered. That sounds incredibly difficult. When is that the appropriate course of action?
The decision to amputate a limb is, as you say, incredibly difficult and is made very, very carefully. It involves weighing the person's chances of the ulcer ever healing, their potential ability to recover and use a prosthetic limb if they get one, and their overall quality of life.
When might it be better than trying to save the limb?
In some situations, especially with very severe, extensive tissue loss or intractable infection, and maybe significant disability already, an early amputation followed by good rehabilitation might actually lead to a better long-term outcome. Faster mobility, less pain than prolonged, likely futile attempts to save a limb that has a very low chance of ever being functional or comfortable.
What else might lead to amputation?
It's also considered if the limb is severely infected and poses a significant threat to the patient's life, like sepsis, or if it's causing such severe, uncontrollable pain that it drastically reduces their quality of life. This decision should always involve a multidisciplinary team, the vascular surgeon, wound care specialists, rehab specialists, the patient, and their family.
And sometimes even amputation isn't the best option.
In the most severe cases, perhaps in very frail individuals with multiple serious health problems, where even an amputation carries very high risks or isn't likely to lead to a good functional outcome, the focus might shift to palliative care, prioritizing comfort, dignity, and managing pain, rather than aggressive interventions.
We've covered an enormous amount of information in this deep dive into arterial disease ulcers. Wow. To bring it all together, what are the key things you'd want our listener to take away from this discussion?
I think the core message is that arterial ulcers happen because of poor blood flow, fundamentally. And the most important goal, if possible, is to get that blood flowing again, revascularization. Diagnosing these ulcers involves recognizing those signs we talked about, doing key tests like the ABPI, that's crucial, and sometimes TCPO2 or toe pressures, and knowing when to urgently involve a vascular surgeon.
And the treatment.
Treatment is comprehensive. It's managing all those risk factors, smoking, diabetes, cholesterol, blood pressure. It's taking meticulous care of the wound itself, understanding if it's healable or not, and crucially, restoring blood flow when possible through endovascular or surgical means. Boosting oxygen levels, including with hyperbaric oxygen in very specific cases, can also play a supportive role. Maybe think of the ABPI not just as a diagnostic number, but almost like a vital sign for your vascular health, just like blood pressure is for your heart health.
That's a great way to put it. So you, our listener, now have a much clearer understanding of this condition, equipped with knowledge about the underlying mechanisms and the factors that guide clinical decision-making. And on that note, consider this. While all these advanced medical interventions are clearly crucial, those foundational elements of risk factor management, especially stopping smoking and meticulous foot care, are often the most powerful tools we have in preventing these challenging ulcers in the first place. What proactive steps might be most impactful in promoting vascular health for yourself or perhaps for those you care about?
That's a really important thought to end on. This deep dive has offered, I hope, a comprehensive overview. For more detailed information and to explore specific aspects further, we definitely encourage you to consult the original medical literature and, of course, discuss any concerns with your healthcare professionals.